Good evening and welcome to the Health Policy course sponsored by the TMC Health Policy Institute. We're now doing session 12 of the 13 promised sessions. Tonight's session is on healthcare manpower, and we have as our moderator Trevor Burt, who's the Vice President for Education Administration at Houston Methodist Hospital System. Dr. Burt.
Thank you, Dr. Linder. It is my pleasure to welcome you to session 12 of the TMC's Health Policy course. This evening's session is going to focus, as Dr. Linder said, on healthcare workforce. We're currently sitting in the center of the world's largest medical center, where it's estimated that more than 106,000 employees come to work each day in a variety of clinical, research, and administrative roles. At each of these TMC institutions, leaders are consistently strategizing and planning how to provide the best care for the patients that present in our clinics, hospitals, and facilities. These thought leaders, four of which I'm thrilled to have on our panel this evening, take into consideration the supply and demand of the workforce across the ever-changing and often expanding landscape and how they'll address the needs of the ever-changing landscape of healthcare. So I'm honored to introduce to you this evening my colleagues. You can find your bios in your chairs or if you're watching online. Starting with my left, Dr. Debra Sukin, who is the Regional Senior Vice President for the Houston Methodist Willowbrook, West, and Continuing Care Hospitals, as well as CEO for our Houston Methodist, the Woodlands Hospital, which is our newest. Dr. Robert Phillips, who is the Executive Vice President, Chief Physician Executive and Specialty Physician Group CEO for Houston Methodist. Dr. Nana Coleman, the Assistant Dean for GME at Baylor College of Medicine. And finally, Dr. Carrie Byington, who has a lot of things, but she's Vice Chancellor for Health Services at Texas A&M, as well as the Dean for the College of Medicine. So we have a great evening and planned for you. I encourage you to engage them and ask them the tough questions because these are the folks that can definitely answer them. So what I'm going to do, similar to last year, is I'm going to kick off with a few questions, kind of set them up. Please ask them questions. Let's start a conversation as well as just having them tell you all of the nuggets that they know. But instead, ask those questions that you're seeing out in your institutions and elsewhere as we talk about healthcare workforce. So I'm going to start with supply and demand. According to the AAMC, the United States is facing a serious shortage of physicians, largely due to the growth of aging of the population and the impending retirements of older physicians. Medical schools have increased enrollment. The 1997 cap on Medicare GME slots has not increased. And the 2018 study that the AAMC conducted predicts that we will face a shortage between 43,000 and about 120,000 physicians by 2030. So is this hype or reality? So I'd like to start off with Drs. Byington and Coleman. Are training institutions adequately training the quantity and type of healthcare providers needed to meet the healthcare workforce needs in the U.S.?
Okay.
There you go.
Thank you so much, Trevor, and thank you all for being here. This is one of the questions that I deal with every day, and one that I think about quite a bit. The AAMC study predicts this shortage of tens of thousands to perhaps 100,000 physicians, given the landscape that we have now. It doesn't really take into account should we go to everyone having access to insurance, because if people had access to insurance, then they would seek care in a different way than they do now. It doesn't account for our rural populations. Should they somehow no longer have the barriers that they have today? And those things could happen, both through healthcare reform and insurance reform, and through technology. So I actually think that the AAMC report underestimates the shortage of physicians. And the last part of that question is, are we training the right types?
Mm-hmm.
Okay, and so I am the Dean of the College of Medicine, but I'm also the Senior Vice President for Health Sciences. And one of the reasons that I moved to Texas was to take on healthcare transformation. And I really fervently believe that a dean of a college of medicine cannot do it. You need to engage all of the health sciences, because we are moving and transforming so quickly, we are entering a time for so many reasons that we need teams of healthcare providers. And so I was actually just as interested in the nursing schools. There are 9 in the system, the Texas A&M system, with 5,000 nursing students. I'm very interested in the pharmacists in that system, the dentists, the public health workers, and we can talk more even about other community health workers as we try to push that, that healthcare down into the community level. But I'll stop there and let you talk about GME.
Yeah.
Thank you so much. Again, a pleasure to be here, and especially with my illustrious and colleagues on the panel. So I'll address the question of the type, because I think you very eloquently addressed the same feelings that I have with regard to the number. So I think there are certainly optimizations that can be made with regard to the type of healthcare training that we're doing. When I think about the goals of the optimal provider to meet the evolving needs of our healthcare systems and their complex and dynamic means, I think there are a few focus areas that we probably could do better. Number one, as was mentioned, the future of medicine is truly interprofessional and interdisciplinary. The types of teams in which many of us trained have really changed and continue to transform and evolve to meet the healthcare needs of our society. I think it's important for our expectations to shift a little bit as to what is the ideal doctor. Compassion, healthcare knowledge, problem-based approaches to care are essential, but what about their abilities to engage in systems thinking? What about their abilities to engage in health system science from quality and safety perspectives? What about their abilities to not only serve as interprofessional team members, but interprofessional team leaders? So I think that as we consider where the gaps are, as much as it is in number, it's also in the types of areas in which we can perhaps better prioritize our training to help our physicians of the future really be ready to serve our patients.
Good. So I want to jump, and I'm kind of going ahead a little bit. So interprofessional, yeah, go ahead, go ahead.
Yeah,
sure.
So actually, I think we have too many doctors. I don't think we have a doctor shortage. I think we have too many. And I think really the way it depends how you frame your question.
Yeah.
And what kind of health systems you frame it in. So if you frame it in a fee-for-service system, you know, where it's driven by the number of procedures that are done, not by outcomes, but by surgeries done, procedures ordered, images done, then we probably don't have enough. But if you do it in a value-based outcomes world, you know, then we probably have enough. And pretty soon there are going to be a lot of unemployed radiologists because of AI. So, you know, they're not going to, you know, we're going to have a lot of radiologists going on and retrain. We're going to have a lot of unemployed dermatologists because, you know, currently we're at the stage where, you know, for typical type, you know, for melanoma and squamous cell carcinoma, AI is just as good at determining whether it's a, you know, a nevus that's not, you know, cancer or one which is. So we're going to have a bunch of dermatologists. Well, you know, I'm being a little facetious, but I think that it really, I think it's a framing question. You know, and, you know, I'd say that, you know, clearly, you know, and then, you know, if you, look, my position would not be Medicare for all, but my position is universal health care for all, and I would say also probably virtual health care for all. You know, so and if we're providing a lot of care through virtual healthcare, which we can, you know, do an enormous number of things on right now, then I think you know, we'll be able to deliver care to lots of different communities that we can't do it now at a price that's much cheaper. And, you know, so I don't think we can. I'll stick with my position. I think we have enough physicians right now, and if you just reorient, you know, how they're utilized and what they do, and if you use a lot of advanced practice practitioners as well, you know, I think actually we're in pretty good shape.
So from a community hospital perspective, agree? Yeah. Somewhat agree?
Well, I would say this. I think this is the best time, actually, to be able to look at staffing both from a physician perspective as well as from a allied health and professional perspective. And the reason why is a little bit of a different play. I would say that we have enough physicians. In fact, we could use more. I think the role and in what they will do as a traditional radiologist will look different. I think the how a surgeon will look in 10 years, and maybe not even that long, will be different. So I think adaptability is going to be essential. I think how we define their roles is going to be different. And I think that the person that's just coming into the healthcare system, regardless of what their role, it's going to be ever evolving. And so I would have to say, particularly as we think about providers and to meet the demand, it has never been a better time to think about how to do that. So, for example, this whole idea of virtual health. I mean, to think about having sub-specialists outside of a place like the Texas Medical Center, which could be considered rural about 5 years ago, which is maybe only 25 miles from the center of this city. You would never imagine being able, for that pediatrician as an example, to be able to offer their patients neurological care without having to drive into the city. Today, that is not the case, and it's ever evolving. Now, you really think about, not even from a community perspective, you really think about rural healthcare, which in a state like Texas, again, you don't have to go too far, but to be able to provide the right specialist at the right time, the world begins to look very different, and I would have to say become that much more exciting. So think about how we can take a role and now pretty much instead of having to duplicate that specialist physically 7 times around, let's say, a health system like Houston Methodist, our ability to really optimize talent just becomes that much greater. So lots of different examples, but I would very much say there's no better time to think about staffing and have lots of other ideas around that.
Good.
It's really a distribution issue. And I think the idea of physician versus healthcare provider, what kind of providers do we want? What do we expect from those providers? I am of the belief that a robot will not replace us, but a robot will change how we practice and actually will make it, I think, much more interesting for physicians. And much of the repetitive work that we end up doing will be taken over, and we will be allowed to develop much bigger ideas and make bigger, broader decisions.
Yeah, and I think we're seeing that with InMed.
Oh, sure.
We're looking at a new type of a physician and what will they be doing differently in the next 10, 20, 50 years. So each of you talked a lot about, or at least a little bit in some cases, about interprofessional care. So I'm going to jump ahead because I want to get to that. Share your perspective on the importance of that. And I think that may look different from a community setting. That may be more important there as you're kind of looking at the whole patient, as it might be here where we typically see that very specialized, you're going to go here for this person and they have their team, versus the whole care perspective. You want to start that? Yeah, that'd be great.
Well, first of all, I always say the world of healthcare is not just the patient and the physician, right? It's really important, more than anything, that it's no longer that we look at the world also as from an episodic perspective, that we truly look at the full continuum. And there are lots of different providers, as you have now spoken about. And so as we think about, particularly in the community setting, it is about creating those medical homes, and that can be defined a variety of different ways. It is about being able to meet the needs of the community without necessarily having to come into the 4 walls of a hospital. And we've talked a little bit about how virtual health, but more importantly, how other mid-level providers can also play a role in that, and certainly from the concept of prevention. When they come into the hospital, and obviously in the management throughout their stay, it's also about the appropriate discharge and also patient progression, because again, no one wants them to come back to the hospital. What we want to do is to appropriately treat the patients where is most appropriate, when is most appropriate at that time. So I think this concept from a team-based approach has become more important than ever versus this episodic perspective. And I also think what that lends itself to is truly healthcare is this team sport. And in being able to leverage your resources and your expertise in a far better way, I think we have the ability to do that by truly putting together all of the appropriate providers, whether that be, again, from an allied health perspective, mid-level perspective, or overall physician.
So, Rob, will you add from sort of the practice plan or physician's organization what that looks like and where that interdisciplinary care is important?
So, And one of the great things about the role that I have, which is that being the Chief Physician Executive, I'm also the Chief Safety and Quality Officer, I'm the Chief Medical Officer, I'm head of the Physician Organization, I'm the Chief Wellness Officer, and Outcomes Research reports up to me. So, but there are two really terrific things about that. And one is that, that we all share a common purpose, right? Because I have a common purpose, so everybody kind of has the common purpose. And also we share common methodology of how we approach issues. And one of the themes that we've been really developing over the past several years is that we're a learning healthcare system. And what that means is that it really comes from a lean principle, which is that we rely on frontline. You know, we believe that it's the frontline worker, whether it be frontline leader who's a physician, or frontline worker who's an MA, or frontline worker who might actually happen to be, you know, cleaning the room that day, that you know, it's from them that we get the expertise, that we get, you know, frontline expertise to help us drive our improvement and get better and to understand what's happening and to, you know, to detect, you know, change them occur and deliver the best possible care. So, you know, by that very philosophy, and you know, and if you take that as a, you know, a rubric of, you know, how do you manufacture things, right? I mean, because we're in the business of manufacturing the delivery of really good care, you know, then that means, but it's fundamentally a team effort, right? Because, you know, you're taking the, you know, team, you're taking the information from every single person, you know, and blending it into what's important. So, you know, we have. I'm not going to take up more time because actually I want to defer to Dr. Coleman, who wrote the chapter in my book on teamwork.
Yeah.
Thank you. So I really appreciate the perspectives that have been shared. And in Dr. Phillips' book, what we really wanted to talk about was reframing our perception of what constitutes the team. And the team is really the patient. And in a values, not value, but values-driven healthcare model, it all starts with the patient at the core. And so when I think of what we need to instill within our learners who are evolving toward independent practice, that's what I always start with. I realize that I'm spoiled because I work in the pediatric ICU, so everything we do is team and interprofessional. There's no one arm of the ICU that can function without the physician, the nurse, the respiratory therapist, the ECMO specialist, the dietitian. Even the way in which we see the patients every day is as an en masse team of 10 to 12 individuals moving from bedside to bedside. But the reality is that's a really small proportion of how medicine actually occurs. And so the commonality through that is the patient. And so what I believe is really critical for our learners is helping to enculturate them around the fact that it starts with the patient and it ends with the patient, to recognize that as interprofessional team members and team leaders, that there's an inherent responsibility that they have to bring others to that understanding, and that even within the role that they play as trainees, that they can actually help to advance that perspective forward, rather than seeing themselves as sort of floating in and out of the care team, in and out of the hospital, in and out of the rotation. The consistency lies in keeping the patient at the core.
So from an institutional perspective, Dr. Byington or Coleman, what are we doing at the medical school, nursing school, PA school, et cetera, level to prepare them for that interdisciplinary work?
So interprofessional education has been a thematic area for at least the last decade, and people are working hard to find out which might be the best training environments to bring people together, how can they do it. And I really think that we need to make these opportunities widely available. There are new skills that have to be taught and respected as part of the curriculum across all of the colleges. So things like communication and leadership training, which you don't necessarily think about in the same way you think about as anatomy or biochemistry. I think these really have to be integrated into our curriculum. A&M has taken a very strong stance on interprofessional education. We have modules that are required for everyone as they start Interprofessional 101. Every college has to take it. It brings us to sort of a common framework on how we're going to interact and talk about working together. And we have a number of things that we do all together as colleges. And one of them is Disaster Day. I don't know if you've seen that. That's the largest interprofessional event in the country. We have about 800 students that participate, and all the supervisors, and 600, 1,000 victims of a disaster. This year was a building collapse, and so I watched as my students evacuated patients out of a building, triaged them, and then provided care in a pop-up hospital, if you will. But we've also done hurricanes, and our students come back to us and say that that experience was so meaningful for them in their real practice. So I think the next place that we need to go, and I talked about this at a national meeting with the Council of Deans just a couple of weeks ago, we're getting better at teaching interprofessional education and the concepts. Now we need to find places for these individuals to practice it in real life. It needs to come in to the real clinical settings. That's the next step.
I want to tag on to what Dr. Byington has said and acknowledge some work that's being done at Baylor that really came out of a need for competency building, really around teamwork. Actually, I have some of my colleagues here who have been part of that work, but really has filled in many ways a gap and an unmet need with regard to interprofessional training and resources. And it's really thinking about teamwork. And so we have developed a program called Team Launch that has a number of components that allows us to bring together our interprofessional students. So from our Graduate School of Biomedical Sciences, from our School of Medicine, from our School of Health Professions, to really bring them together around teamwork skills as one of the core interprofessional competencies. And to your point, we have now in the next year made this a requirement for all of our incoming students at Baylor College of Medicine across each of those schools. So every year there will be a cohort of students of about 400 that really will be leading that charge. And it's our intent to actually take this through our graduate medical education training as well.
Great.
There's a question, Trevor.
Oh, I'm sorry.
There's a question.
Yeah. Go ahead. Oh.
So, Dr. Coleman?
Yes.
Very good. Dr. Coleman, does that include your trainees? Because some of them may have been, it's like retrofitting. You have the new ones that are in the school so they can benefit from the new way, but are you retrofitting also your trainees, your interns, and your fellows? Thank you.
Thank you for that question. So yes and no. So I happen to have two hats within Baylor. So one is in my assistant dean role, but then also in directing the program that I just referenced. So our intent for the program is to take care of all of our students first, but we're actually going to retrofit also for our clinical faculty because they have to have the same nomenclature, and also for all of our residents and fellows. They do get portions of teamwork in the orientation we do already for them, but it will actually be over the next couple of years formalized where we expand it for all members of the clinical training team. Thank you.
So what are some of the things that you're doing in that regard? So for other institutions like ours, I mean, the demand on time is critical for residents and fellows and medical students. How do you carve out that time if they're already in the setting to make sure that they're kind of able to not only do their daily work, but expand that role and understanding how to work at the top of their license or specialty or collaborative spirit in regards to interpersonal care? Why don't you, yeah.
Sure.
You're doing it, I think.
So for our residents and fellows, we try to have different touch points at which we deliver the education. So first entry point is when they're coming to us. So there's a lot of work that we ask them to do to really set their minds up for working as part of teams and complex interprofessional teams in their preparation and pre-matriculation modules and trainings that we've developed. Then they work with us during their incoming orientation. So many of you may be familiar with the Clinical Learning Environment Review Program from the ACGME, which accredits all training programs or most of our training programs at Baylor. And through that program, it has given us both a language, a nomenclature, but more importantly, really a bolster in the terms of the kinds of work we do, in that by accreditation requirements, we are required to teach them the skills. There's actually a standard that says we need to ensure that our faculty and trainees have adequate training. So we are actually in the process of developing some new methods, including what we would call just-in-time training, mobile applications. We already do quite a bit of simulation within our programs. And then we also have actual programs that have set up boot camps that allow this to be something that happens throughout their journey. Our intent is to not overwhelm trainees, not to overwhelm programs, but to take the work that they're already doing on a day-to-day basis, be it morning report, be it leading a code, and actually give them the skills to debrief and apply to those already existent parts of their training.
Okay. Debbie, you mentioned something earlier about creating a medical home and kind of the importance there of that interdisciplinary or multidisciplinary care team. Does it continue to include the hospital that they're coming from or the organization that they're coming from when they go out there, or is that something that you try to create in their community?
I think it's a combination of both. You know, this whole conversation about training and really pulling everyone together. Again, it's not just the physician. So what I would say is that, you know, the healthcare system, regardless of what organization or entity, has to be committed to truly pulling together the whole continuum and all of the providers around the team to really ensure that the patient is getting the right care at the right time at the right place. And I say that because as we talk about training, you know, healthcare, particularly with all of the innovations and the influx of continuing new providers into any system, really requires this continuous education and I would say overall training protocol. So I just have to say, before even getting to talking about the medical home, I mean, I've opened up 4 hospitals in my career at this standpoint. We launch new programs. I will tell you, all throughout any one of our organizations, and every time you start something, it is about, and I will tell you, we do day in life scenarios. The public would expect us that to practice. Right. And the practice isn't just necessary for the physician. The practice is necessary for how the physician practices, with the whole team coming around, including the patient, at the heart and the center of what we do. So it's really important. And again, I would say these tools and these concepts, not only day in the life scenarios, but also the whole influx and creation, now it's been about a decade, but truly of simulation labs. I mean, this has just become the standard. No one needs to practice anymore on, you know, from a human perspective, it being a first time. So I think that's really important. Now I'll get to the medical home. From a medical home perspective, it's really important. A medical home can either be, as I said, defined in a formal way. So if your organization or healthcare organizations that say, we are going to define in our own way in terms of discharge planning to primary care physicians, certainly out or some sort of connection. Again, now today it can be done with virtual health on discharge planning. But I would also say, just having this conversation today, there are many patients, a lot of patients that come into all of our hospitals that have no primary care physician. And they also have no ability to pay. They have no insurance. We are fortunate in, while it's never enough, and there aren't enough places that do this, we do have federally qualified clinics in Houston. We also have some clinics, I'll give some examples like Northwest Ministries or Interfaith Community Clinic of the Woodlands. I think we can go around town and pick them out. It's never enough, but they are resources. What's important is that the team, the discharging physician, identifies whether the patient has a primary care physician or not, and then links them up to one of those different resources in terms of that medical home. Again, I think that this concept of a medical home is going to continue to evolve. Let's just think about how virtual care plays a role in that. And even if it's not a primary care physician, it might be a nurse practitioner. And what we have found, even in doing our own population health studies, we have found by doing the discharge planning and really supporting it with our outreach nurses, that by simply making a phone call every week to a patient who is quote unquote at high risk because they have heart failure, by making phone calls and asking key questions, we can do a better job managing that patient without having them basically come back to the emergency department. So lots of different ways to address that. And again, I think it's a really exciting time in healthcare for us to be able to begin to say, how do we expand our reach?
I would like to further comment on that. I do believe that we are at a time where we're pushing more and more care out into the community. And I like to think about that as both empowering patients and empowering communities themselves. There are many things that can be done, and we're exploring a couple of models that I think are interesting. Texas A&M is a land-grant college, so we have a duty to serve every county in the state of Texas. And there are great needs in the state of Texas. Many counties that don't have physicians. We work in South Texas where there are a lot of healthcare disparities. We've begun to look at agricultural extension agents who are paid by the state, whose job it is to help you grow your crops, to manage your farm animals. We have been exploring training them in chronic disease management, like diabetes. And for the last 3 years, we've had diabetes program through our agricultural extension agencies in South Texas. We have saved $52 million in healthcare costs. That has produced amazing outcomes for the patients, and they are much more empowered to know about their disease and to manage their disease in a way that I, as a healthcare provider, cannot do. I might have 15 minutes max if they come to see me. They have diabetes for another 364 days out of the year, and they have questions that I can't answer. We have also begun to partner with a hospital system in Brazos Valley in a 9-county area around things like heart failure and pneumonia that have 30-day readmissions, where we send interprofessional teams of students to the home for the 30 days. So they will see, what is your oxygen saturation today? How much oxygen are you on? Did you take your Lasix? Let me look at your pills. Do you remember you have your primary care visit and it's at 3 p.m. tomorrow? Do you have transportation? And all of it is documented within the same electronic health record as the hospital. So while it would be very difficult for the hospital to afford to send a doctor, a nurse, and a pharmacist to the home every day for 30 days, for my students, it's a remarkable learning experience, and it contributes greatly to the health system.
So we have an avatar for that. So we have an avatar that sits in the patient's home, and they get to be friends with, and it asks them, have you weighed yourself today? What's your weight? Are you short of breath? Have you gained any weight? You know, and then at a certain point, when they, and I'm actually not being facetious, and I think it's wonderful that you send the students to those places, but I'm just talking about, you know, I'm being a little bit of the, not curmudgeon here, but you know, a little
Disruptor.
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 But,
Probably keep them around.
but that it's, you know, so that's what I'm saying. I think, you know, there's some of these things. I mean, look, there's no question you do better if you have a medical student in the house than a pharmacist and somebody else. But, you know, but there's going to be new stuff that, I mean, we get a lot of information from this avatar. And then when the question isn't right, or when there's too much weight gain, or when they haven't taken their furosemide, or they get mixed up, they can't answer the question, you know, then it directly goes to a nurse, you know, who picks up that phone and then talk to the patient, and then then I'll get the patient in. So,
yeah. So you lead to my next question. Thanks for setting it up. A lot of these rural communities that we're seeing these kind of new techniques in might be averse to those changes, might be averse to the technology of an avatar or something that can send messages back to a central place for confirmation that they're doing the right things, taking their meds, whatever. How do we, as a healthcare workforce, manage that change in culture at that patient level or family level to give them that comfort of knowing that you don't have to physically see someone, or it might not be as often that you see someone, but you're being monitored in that way?
Go
ahead.
Just to jump in?
Yeah, sure. Yeah, jump in on
I mean, from my perspective, it's about how we are integrating these different technologies into the workforce. So as an example in that scenario, it is right in the introduction, it's not just about the avatar. Obviously, the avatar sits as a tool that's backed within a whole healthcare continuum. I think it's really important as we introduce that. Same thing is true, I'm sure many of you have read about this with EICUs, right? So it's like a virtual health, but essentially it's backed by intensivists that sit in one spot and basically are reaching through cameras to ICUs outside in smaller communities, not even so small, quite frankly, because it's too expensive for them to be able to provide 7/24 full-time fellowship-trained intensivist coverage. And the ability with that tool, right, allows them to have that level of expertise. Now, if you just left it and everybody in the patient thought, I'm only going to be managed by essentially a video camera, that would be a problem. It's how it fits in. And then it's also how you layer on the other providers. Now take an EICU that actually has a full-time nurse practitioner in there. That also then knows that they are backed by an intensivist. Now layer on and say, well, is that appropriate 7/24, or is that only basically good certain hours of the days, but you actually need physically an intensivist in on other hours of the days? This is that adaptability. This is that, I would say, the creative aspects that today with the tools, we're actually able to extend our expertise in a way that we've never been able to do before. So I think the introduction, in answer to you, Trevor, is really in how we introduce the new tools and technology into, and truly, it's not as easy as you think in terms of who plays what role and when.
Yeah, that team-based care
Right.
kind of plays a different role. How do we prepare?
Well,
Go ahead,
I think
and then
you
I'll-
have to be very patient-centered in this, and there are some generational aspects to how comfortable people are with technology. I mean, there are my students, their average age is 24, 25. They would prefer this. They would feel much more comfortable with the avatar than having to make an appointment and come to some building that they have no desire to be in. That's not necessarily the case of the 81-year-old. So there are some generational things, and part of what I think healthcare providers have to become better at is, again, our communication skills, particularly with and around technology. How do we communicate through that wall of technology, with that wall of technology, and how do we still maintain a human connection that I think our patients do crave?
So, Dr. Coleman, how do we prepare our students for that? How do we prepare medical students? I'm hearing that a lot of them would actually like that because they love their phones and everything else, but how do we prepare them for this aspect of it? To know that there are going to be patients that might not prefer that, but if this is the way we're going, how do they temper that with that same level of care that 81-year-old has been expecting?
So I think we first start backwards, because who are their teachers? Their teachers are their patients, but their teachers are also us. So I think of one of the areas in which we serve in the ICU service at Texas Children's, which likens to a lot of this. So we are a quaternary referral center, and so there are some weeks where I'm in the ICU at the bedside, and then there are some weeks I'm in mission control. And one of our newest technologies is the ability to see our patients when we are picking them up from all over the world, literally, and bringing them to us. And it's a new technology. It used to be if you were doing transport, you go and you see what you're going to see and do what you have to do in the field and get the patient back. And so one of the things that we've started doing is bringing our trainees into that fold. But I think first, we have to, as faculty and teachers, acknowledge the fact that we do need to be versatile, and we do need to meet the learners where they are in order to keep them engaged and in order to sustain their interest in what we're trying to do, number one. I think we also have to educate our faculty and give them the confidence, because I don't necessarily think that we are sometimes late adopters or older individuals feel that because they don't want to learn. It's because they're sometimes stymied by or intimidated by the technology and do not feel that use of that technology puts them in a safe position for care. Because if you don't trust that you're going to be able to make the right clinical judgment, if you're not laying hands on that patient, you're not going to feel comfortable with that. So once we begin with that sort of the understanding that this is a way in which to optimize care, then we go for our learners. So what are we doing now? We provide them with opportunities to integrate with these systems. We make it normative. We develop programs that meet them where they are. We actually just had a conversation about this earlier in the day, and a colleague, a vice chair of education with whom I work, said they're never without their phones, never without their phones. So we have to meet them where they are. I thought I saw a hand.
Sure. Question? Yeah, go ahead. And then I'll, go ahead. Oh, bring a microphone to you.
So I have two questions. One is the selection for the medical student changing, where we're looking for those individuals that have the ability for gamification or math, high level, programming skills? So again, is it changing? And language. And then the second is, what are the new levels that the trainee can jump into? Like the intensivist, I think, is relatively newish. And so what are some of the new positions? Like, we have the nurse practitioner, et cetera, but what are some of the other levels beside being a doctor that can hang a shingle or go into the hospital? And so can you help me with some of the new flavors of the workforce for the physician?
Yeah.
It seems to be becoming more and more important. Thank you.
I'd like to comment on the selection of medical students. So we saw such a great need that we've actually developed a new track within Texas A&M's College of Medicine, and that's the engineering medicine track. So these students will come to us, and the first ones start in July. In June, they do their pre-matriculation work. And so they will come to us with an undergraduate degree in engineering. So they are very quantitative. They've been trained in that way. This is a program in which they will learn technology and engineering at the same time that they're learning medicine. And they, in 4 years, will get an MD degree and a Master's of Engineering. I hope to teach them systems engineering as part of the training, because as we see health system consolidation, they're going to need to understand how to work within systems and how systems operate. So
also with Houston Methodist?
It is, yes. Our clinical partner with that is Houston Methodist. And so we think they'll get exceptional clinical training. They'll also get exceptional training around engineering and those skills. I believe this is creating a new type of healthcare professional. We call it a physicianeer. And I think a decade from now, someone will say, I want to be a doctor, I want to be a nurse, I want to be a physicianeer. And we will understand that that's a different kind of healthcare professional than we have today. So that's a very new, cutting-edge healthcare professional, if you will.
So, so framing for this, so when we were coming up with the name, I didn't want it to, I was really opposed to being engineering and medicine. I wanted to take the ampersand out, and I wanted it to be engineering medicine. So actually in the agreement, it says engineering medicine. And the reason for that is, to me, it's a verb. If it's engineering and medicine, then it's a noun. But from my point of view, as engineering medicine, it's a verb. And we're engineering, and I'm glad, I know we're on the same page on this. I mean, how we're going, because what Debbie was saying, 45 minutes ago, this is the most exciting time ever to be in healthcare. And I probably said that 40 years ago too, but
but it really is.
But I really mean it.
But it really is. So and part of it, because we're changing the workforce, we're changing how we're saying things. We're becoming an industry. I mean, we're finally, we're standardizing what we do. We're moving from being a guild to being something that produces something that is comes out the same every day. Where with the asymmetry of knowledge is just being completely disrupted, right? So that it used to be that we were this guild and we had all the information, we had the textbooks, and we're the only one that had the biochemistry text. And and I know I'm a little nerdy because I just got my 9th, I'm not going to tell you what year, but I just got a new edition of my modern organic chemistry book, and it's at my bedside, and I'm going to start reading about alkenes again. So, so we're at an amazing point where we can really change how this how everything works, and so that's why it really is a terrific time.
But I would just, this is really, I will tell you, important. So today, when I interview to recruit a rheumatologist, which in this city I can count probably on 2 hands at best, I interviewed recently a rheumatologist, just graduated fellowship training at Stanford. She sat across the table from me, and she actually told me, I said, what have you been doing over this last year since you've now graduated the last 6 months? I'm in the process of recruiting. She said, oh, I do virtual health. I just had a baby. I don't go to the hospital. I don't have a clinic. I work for a company. I work from my own home. And those types of new opportunities never existed for women, particularly, who wanted to enter the workforce and do it differently and have all the talent and expertise in the world. But I will also say, I was interviewing her not just because she was a rheumatologist. Now I'm like, and that's what we need to be doing. So that's different. The whole, I would say, evolution of intensivist or hospitalist, I'll tell you, probably 60% of my hospitalists just happen to be female. Part of it is they get to work, they know they know they work 7 days straight, they work 12-hour shifts, and they are able to organize their life in a way that allows them. So there's lots of different opportunities today that, quite frankly, right or wrong, it just didn't exist. And I would say, take that for physicians. I say the same thing from an allied health perspective. I mean, we're looking at ways today, and I am going to use the example of bots. So we now have incorporated at Houston Methodist, as an example, 5 different projects where we basically have created bots to do redundant work. What would a redundant work process be? Quite frankly, what we have to do in terms of all of the paperwork that's necessary to essentially file to an insurance company on 4,000 records every single day in order to ensure pre-certification and that someone actually can go and have acceptance in terms of moving forward. We have bots instead of physical human beings that are taking their time to essentially do paperwork. What we're really using their expertise on is a better face-to-face interaction on things that really need to be understood and explained, like about your copay, and do you really understand it, and why your deductible is X. Much better use of people who, that is what I'm hiring for, is for that conversation, and oh, by the way, they had to do all the other things. So it's really a different day, and it's exciting. It's exciting as to how we can actually, but you have to have a workforce that is committed to evolving and adaptable, without a doubt, and willing to train and retrain.
That's right.
Yeah, right there.
Yeah, hi, my name is Tom Nix, and I'm with RIA Health. We're a tech-enabled telehealth medical practice that treats alcohol use disorder as a center of excellence. And listening to Dr. Byington and Dr. Coleman talk about the training and interactions that are coming from digital natives, people that have been using phones since they were children. One of the things that in my previous experience that we saw was that we started seeing a consistent drop in empathetic skills, primarily because empathy comes through face-to-face interactions, and more people as they grow and evolve are looking at digital screens. So as we hire our care team and realize that part of the outcome success that we've had has come from these interactions that we're delivering through virtual means, whether it's phone or video visits. But when we think about recruiting at scale, how do you see either helping people improve their empathetic skills in your programs, and what are you noticing, and what have you seen that's been effective?
We spend a lot of time talking about that, and one of the founding departments in our College of Medicine was called Humanities in Medicine. And we have continued to have, some people have said, do we really need humanities in medicine? We're going to engineering medicine, we should have an AI department. Is this an outdated department? But I would argue that we need it even more. We have to learn how to interact across a screen. We've talked about that. But we also have to help people who primarily interact across a screen interact in real life. And I had a beautiful example of that yesterday. We have a cadaver memorial when we complete anatomy, and we've completed it now. It's April, so we have a memorial service. the students run that and put that together, and it had been primarily a student only, student and maybe the anatomy professors. And I said, I think we really need to invite the families of those individuals who donated the cadavers. And that happened yesterday for the first time. Wow. There was not a dry eye in the room. The interactions that the students were having with those families, it gave an enormous sense of closure to the family, but also to the students. And today my inbox is full from my students saying this is the most impactful thing that happened to me in this whole first year of medical school. I will never forget it. So we need to find these kinds of opportunities and remind people why we are in the healthcare industry, if you will.
Yeah.
I wanted to comment on your thread, Dr. Sukin, because it struck a chord with me. When you think about all the resources that we have in the system and all the different professional roles, I think one of the things that seems to sometimes hamper the best use of the talents is you have different turf wars between who can do what. And so your comment about the bot taking on the repetitive work and leaving the higher order skills to others to free them up to do that. One of the examples you hear a lot of times is, you know, nurse practitioners are really trained in the sense of primary care. So as you evolution and letting people work to the full extent of their license and training, in my mind, that frees up others for those more complex and difficult to manage problems. And so that thought line really resonated, and it's interesting.
I want to go back to the question that was raised, and thank you, with regard to how do we help to cultivate that empathy. And I want to relate it to the previous question with regard to how do we select. So by the time those medical students get to the point where they're selecting where they're going to continue for either their residency or in some cases their postgraduate fellowships, they're formed. And so a lot of that work of sort of holistic evaluation to think about how do you have a composite class of individuals who are at once dynamic and diverse and at the same time really share common values and goals, I think is very complex. At the point where we are selecting for those who are going to move into different specialties, I think a couple of things come to mind. Some of the trends. Typically, many of our applicants are older. They have had different life experiences prior to coming to even medical school. And even within medical school, individuals are pursuing secondary degrees. So by the time they come to us for residency and or fellowship training, they might already have earned their master's in education, in business, so their perspective is a little bit different. I think another very important piece within training is time for reflection. We talk a lot about wellness and well-being and how we need to have fewer work hours and more yoga and more sleep. And I say that without any facetiousness because all of those things matter. But when we think about and we talk to our trainees about sort of the single potential area which would maybe enable them to be more human and humane, it's making sure that they are okay. So what do we try to do? Debrief with them after critical events, but even after the non-critical events, by investing in wellness at an institutional level so that there is a permissiveness around not being okay, a permissiveness around being human and humane.
So can I say something? So first of all, I totally agree with you. I think it's wonderful. I'm sensing a little bit of divide between this side of the room and this side of the room.
What divide?
He's disruptive again.
So
I don't sense anything.
no, I'll tell you what I do. No, because it was like when you I guess it was in your comment about being an industry, and I'm wondering so we deliver healthcare, okay, the two of us deliver healthcare. These two guys teach healthcare, and you deliver healthcare too.
And so do I.
So you
and,
okay.
And so do I.
But I'm saying like we do it on. We've got 25,000 people that work for us. We're on scale, okay? And these guys are like, 13 people, stuff like that. Although you're dean, I mean, that's, but I'm...
Keep going, Bob.
Start distance more of a divide.
And I think
No
it's true because
respect
look,
for
you know, look, I've been in the academic world forever, NIH funded 20 years, I get it.
Yeah.
But I'm just wondering, I mean, am I the only one that senses this? Do you guys sense that we're talking a little different? Because I'm just wondering if we are going to develop the same, we're all on the same page, right? I mean, you know, we're all patient-centered. We want to develop really good care. We want to make it great for our people. Is there anything like that you think we should be doing differently? That's, you know, I'm wondering.
From a hospital, that's a great question.
That's a great question.
Yes.
Yeah, and I think we talk a lot about kind of how are we preparing them to fit into your model, but what if your model's not easily adaptable, or
Well,
you know?
the only thing I would say this, from just not only from an educational perspective, but I'm going to say myself, who's been committed to continuing education, of which over 25 years has vastly evolved. I mean, as simple as you can appreciate, there were no online courses 10 years ago, 15 years ago for any master's degree program, or no less college. So you just kind of have to think about that. But what I will say is, I think how we evolve, you've got to start it from essentially college to graduate school, whatever anyone's interested in, is that this is an ever-evolving industry. It truly is. And we have to have not only compassionate caregivers, healthcare delivery, anyone that's in the continuum, but you have to have individuals who are coming in who are adaptable. It's just the person that wants it to be like how it is today and thinks that that's what it's going to be tomorrow, we're not doing them justice by pretending that that's the case. So in our foundational educational, regardless of what it is hardwired. I'm not saying, because when I went to graduate school, they said it's really the worst year. You know, it's really healthcare reform this year, right? There's going to be no jobs out there for all of you because we're getting rid of all the hospital beds, right? I've watched that cycle. So I think I think it's really important. And the other thing from a culture perspective, I spend a lot of time on culture. And that's going to be true whether you actually run a hospital, run an organization, a clinic, or a virtual care organization. Culture and hardwiring, that the reason I talk about this all the time, the reason why one person's going to get the job over the other has nothing to do with their skill set, because by the time they sit in front of me, I make the assumption they're the best of the best in whatever we're hiring for. What got them the job was what we believe is that cultural fit, which goes back to the values. So I would say, as you ask, how do we have this conversation? If we're just training physicians today, or nurses, or whatever the role is, just in their industry dynamics and not addressing this, we're not doing them any justice going forward.
And I would say that we need a closer partnership between academic health centers that are training your workforce and the stakeholders who will actually hire the workforce. And that, I feel like, has been missing at a national level. I've brought this up many times with the AAMC. With the healthcare industry consolidation that's going on in the country, more and more these are large corporate employers.
$22 billion.
Right. You should have a very big stake in the kids I graduate and what they are graduating able to do. And there needs to be a way for us to be at the same table, because I don't think there is a divide. You want a compassionate and qualified healthcare professional who is flexible and able to deliver. I, as a dean and as a patient, I want excellent healthcare every time in every location at a cost that we can sustain as a nation. So I think there just needs to be more opportunity for the stakeholders to be at the same table.
Great.
And I've actually had the privilege of interviewing these InMed candidates for the very first class, and I wear really the Methodist hat, but in an interview capacity, the A&M hat, and it was pretty inspiring. And I mean, some of these kids came in, perfect MCAT 4.0, great, okay, you know engineering, I don't need to focus on that.
No.
What I'm looking at, can you talk to people? Do you show that you care about people? And when we do these scenarios and these interviews that are very behavioral, how are you going to respond, and do you show any empathy when you're talking to a family that one of the scenarios, you're talking to a family in a park, then you can tell that the child needs medical care immediately. What do? You know, you have some that go, I don't know, well, you know, maybe I'd get them here, there, and you can tell very quickly they don't have that ability. Others will say, I'm going to take them home, I'm going to put them in my house, we're going to, I'm like, wrong answer.
So a little to that.
Wrong answer, but somewhere in between those is where we want to be. But it's still there. And I think, you know, as I looked at those candidates, it was building that, what does a good medical student look like? And coming from a very different mindset of engineering and math and very logical to what does our hospital need? And knowing our cultures, A&M's culture, Methodist culture, how do I bring these 25 or 50 students into our organization and expect them to not only live our culture out, but watch that fluctuation that Debbie was talking about, and how are these things going to change, and how are they going to change with it, and what are they going to help us to develop? Because that's the whole intent of that, is to see where healthcare goes next with this next group of students. I saw a microphone. Yep, go ahead.
Yeah, sure. So I'm struck by a lot of the things that I'm hearing around values, around empathy and teamwork, and a lot of that stuff. And Dr. Phillips, you mentioned, you know, what can we be doing? I'm sensitive to the fact that we're bringing people in under these pretenses of, we don't care about test scores, we care about holistic, we care about empathy, we care about these communication skills, and then we're spitting them out and we're measuring them by test scores and procedural cases and RVUs and clinical volume. So I wonder, what can we do to serve ourselves a little bit better on that end game? Because I think we know that assessment drives behavior, so I think we're not doing ourselves justice and providing them with a realistic preview if we paint this beautiful world where everything's fluffy and beautiful, and then we just throw them out and spit them out and say, now go make a lot of money for us.
Yeah. What type of role are you in?
I'm an assistant dean at Baylor College of Medicine.
Okay. Just curious.
I don't know, you tell me.
That's why I asked.
Do you want to talk about step one?
Yeah.
Let's talk about step one. I think that is an issue that we brought upon ourselves. And because there are so many...
Tell everybody what the issue is.
Oh, so step one is the test that the medical students have to take first after they've completed their basic science training, and then sometimes they take it a little bit after they've started into the clinics. But because it's one of the test scores that's available for residencies to see, it's high stakes, and people, it becomes an easy screen when there are not enough residency slots in the country.
Right.
And if you're an orthopedic surgery residency getting 750 applications for one slot, you've got to have something that can just trim it down. And our medical students are living in this severe epic of having to, their whole being is one number. And we need to change that. And that is a national conversation about, can we make step one pass-fail? What would happen if we made step one pass-fail? One of my deans has come up with an idea that I think is phenomenal. Make them pass step one before they get into medical school. They can do it. These kids know science. They can do it. Make them already have passed step one by the time we take them into medical school. How would that change things? We have to be creative, because it can't just be one number.
Yeah.
And I think, Dr. Gardner, to your point, it takes creative, fearless leaders. So I can think of some mentors, leaders, section heads, departments in which I've worked, where while those other metrics are valued, it is clear at the beginning that that is not what defines your value as the individual. And a lot of that has come from really groundswell of individuals who may not fit exactly within, well, you are a 0.x FTE. So your RVUs really can't determine the quality and the quantity of how well and how hard you're working as a clinician. So what else? So I think leaders have to be prepared to undertake the conversation, and they also need to invite, because I know as a faculty member what I think I should be doing, but I may not have the space in which to share that. And so conversations around what defines your value within the organization, within the section, within the department, rubrics created to really help individuals fit into the lens, not just the RVU bell curve, but then also just even thinking about honestly, some of the evolution, to your point, with regard to ongoing maintenance of certification and other areas of validation, where at least for faculty, we're beginning to move outside of everybody has to pass their boards every 10 years, but now ways in which we can drive the learning through a self-directed means and really focusing on areas where I may have gaps and I know that I need to improve as an individual.
You know, what I would say though, and you know this, is that the hospitals for all Medicare, right, so HCAHPS, our patient satisfaction scores, all publicly reported, transparent, and we're actually paid based on how well we do. Yeah. I mean, sharing that with physicians for the first time, they've just gotten out of residency and they're fellowship trained, and we're now just introducing a concept to them for the very first time. That's a problem. And it's a problem because if you work for an organization like Houston Methodist, where we actually put that in your contract, that the expectation is that you won't just achieve X RVU to get your salary, but it's also dependent on the how you deliver the care, on HCAHPS scores. That's a component of. And so what I would say, again, going back to how do we train, this whole conversation around communication. And I can tell you, when we interview a physician and they're negotiating, they're also watching their attendings, and they've been listening to the conversations. And if they hear their attendings going and negotiating with the hospital in terms of, you need to go negotiate X for sign-on bonus, X more for this, X more for that, I can tell you they're going to play that game and push us so hard, they can go down the street. Because you're setting up a conversation of where we're trying to dialogue and build partnerships. And so I think a lot of this, I would just say, it is also about how we all model in the healthcare system, how we collectively work together, how we compassionately want to be spoken to. And I can tell you that is vastly different, as you all know, in the environments than it was 20 years ago in terms of what the tolerance of the conversation and the communication style could be in healthcare. And I think that is a start, but we still have a long way to go.
Yeah. So can I ask you a question? Yeah. So what type of world do you think we should tell them they should be in?
Well, I think you should obviously give them a realistic preview, but I'm wondering if, I think to the last point of putting some things in their contract, putting some things in their performance appraisal, creating expectations around, we don't just care about how much volume you make, we care about all of these other metrics as well. We care about the teamwork. You're gonna have 360s every year. We care about empathy. Your patients are gonna be rating you. I think just creating that as the outcome and the desired endpoint would just make this a lot more relevant for everyone involved.
But they don't like that, I can tell you. So I will tell you, most my faculty would rather be judged on their work RVUs than on what their quality metrics are, what the patients think about them, and because every day they feel they're on the line for performance. Yeah. So it's complicated.
Yeah, I think we have to flip the script, but like things like this, I think will help us along the way.
But I think your point that a student has to know, or a resident has to know that this is coming. It shouldn't be a surprise when they get a job. And I think that's where we can do better and where we might do better together. I do think we're into this big period of healthcare transformation, and it's hard. And one of the things that helps me, and I think can help us, is to anchor in our values. And so we spend a lot of time at A&M going over what our values are. And you can ask any Aggie what the values are. I can ask Trevor right now, and he would know.
Leadership, selfless service.
Respect, excellence, leadership, loyalty, integrity, selfless
service. I know I
Yeah.
care. I can tell you that.
And those are very well aligned with the values of any healthcare profession. They're very well aligned with Methodist values. And we've actually started very public recognition of values at every meeting that we have. We reward and award people who are caught doing, living their values. And we have coins that we give, challenge coins that we give. But you need to show people that is then tied to how well they do in the organization. So that those who are living the values of the organization, they should be advancing if you really believe that that's, if that's important to you. Yeah.
I would add, I have the perspective of seeing the medical students that we now have on our campus, as well as the residency groups. And during orientation, something we never did 10 years ago or so was bring out that very colorful HCAP sheet, because they weren't getting that. They are, medical students, residents are typically the very first person that a patient might see. And that interaction, they're not held to that at all. It's their attending that's held to that very colorful sheet and who is disappointed that that's part of their contract. So we had to make a conscious effort to introduce them to that and say during orientation, when you go into the patient's room, your very first impression might be on you, but when they do that survey, it's actually on your attending. And how do you measure that with not making it kind of every day they're worried that they're going to, do something wrong and it's going to affect their attending, but measured in the way that they are prepared. So when they are having those conversations with Debbie across the table, that they get it and they go, you know what, we knew this was coming, this was the expectation. Medical students, we've not entered that realm just yet, but we've started to tell them about those values and the expectations that we have as an organization when you're seeing our patients, because it does come back to us in the way of that survey. One second, I think Dr. Cole, do you want to?
So did you want to, please go ahead.
So Houston Methodist is one of the forward thinkers in our Texas Medical Center. So I consider you all a spurious point. I consider A&M a spurious point, and I consider Baylor a spurious point. So how about the rest of the organizations out there relative to how are they dealing with workforce and the visibility for trainees from A&M or the Baylor or UT Health? And how are those future trainees going to be able to judge the rest of the world? Are there standards? Is there something? Thank you. Teeing up Dr. Coleman.
Yes, so that was actually very much on my mind, so thank you for that inquiry. So the good news is that there actually are standards. And so I had referenced earlier the Clinical Learning Environment Review Program, CLEAR, which is actually what a lot of my work, almost most of my work within graduate medical education is focused on. So what is that? For those who may not know, the ACGME that accredits our training programs has 6 core focus areas. So quality improvement and healthcare disparity, 1, patient safety, transitions of care, professionalism, wellness, supervision and accountability, that in which they actually have regulatory standards that every sponsoring institution in collaboration with their affiliate hospital partners are required to in which they're required to demonstrate compliance. 3 others coming down the pike: teamwork, collaborative learning, and interprofessional practice. So spuriously or otherwise, when you speak of Baylor, Methodist, other really leading centers who are doing this work, we're doing it because we believe in it, but we're also doing it because it's kind of now the letter of the law, and that's how programs are being judged. So in reality, what have we done at Baylor? So we developed a process called the Clear Inter-Affiliate Process, bringing together our major affiliate partners to think about how can we do this constructively. So through that process, we developed a series of action items, sort of like a strategic plan for Clear, that allowed us to think about how are we going to do this, short-term, interval term, and long-term. So as an example, to your point about how are we going to educate our trainees to expect data? So one of the requirements of CLEAR, as an example, is that our trainees, residents and fellows, actually receive data about their own performance metrics. That is a requirement. And so our hospital partners have worked eagerly and ferociously in the past year, as we're coming up on compliance on July 1st of this year, to make sure that when the faculty get the every 6-month OPPE performance evaluations, so too will their residents get performance information, their throughput in the ER. How well are they documenting the social situation for their patients in clinic? Things that previously we weren't sharing with them. The other important piece of this work is thinking innovatively, how can we, again, take what they're already doing so that it doesn't feel like new work? So when we think about communication, and we have 360 evaluations that come from patients and families and social workers, we are now helping to develop a paradigm that when they come to Baylor College of Medicine, when they step in the door, that there is an expectation for interprofessional rounding and how it works at all of our sites. There is an expectation to ascertain necessity for supervision. Things that previously just kind of happened or were left to chance with significant heterogeneity among programs that are actually now going to be standardized for all of our learners.
And the same is true in undergraduate medical education through the LCME accreditation standards. And they do now include interprofessionalism, and they look at the learning environment for a lot of different activities that have to be very explicit for our learners.
And I know Dr. Phillips and I had worked on with the AMA, they've got a proposal out for reimagining residency. I have a feeling we're going to see reimagining medical school and reimagining nursing school and all of these other things, because that is the direction, and you're going to have those guidelines. Otherwise, it's just too loose. And those expectations that hospitals are going to have, all of them are going to have, you're not properly preparing. So we have just a few more minutes. So I want to give the panelists one last say-so and kind of how their organization might be addressing these things, the needs of their institutions, and any final statements you might have. So Debbie, if you want to kick it off, we can.
Yeah, I think you have a sense that I'm very proud of the organization that I work for, Houston Methodist, and the fact that we actually made a concerted effort. We actually set out to say, how will we, from a technology and a health transformation perspective, how will we lead in this avenue? And I will tell you, it was all of us as senior executives sitting around the table and really organizationally reorganizing to say and identify a leader to really lead us, and then actually bringing in experts to help teach us. And then again, identifying different areas where we wanted to focus on. So again, I'm really proud of that. I will tell you that it takes that level of commitment for even myself as a healthcare executive to educate myself and learn about how we take these tools and technology to transform the work that we're currently doing it, and what you hope is provide a superior outcome. And that's really what we are attempting to do. So again, I think that it spans the full continuum, and I hope that you've heard that tonight.
Yeah. So I'd say that one of the things that we've been trying to do, and I've been fortunate to be able to work with the AAMC and the AMA on this, is creating a new workforce that not only has excellent clinical problem-solving skills, but also excellent managerial skills, financial skills, and operational skills. Because that's what I think we're going to need, going forward, to be able to really address all the problems we have and deliver healthcare to everybody in this country who deserves it. Everybody deserves it, and in a way that is cost-effective and value-based and outcomes-based.
I've had the opportunity to share some of our work, and what I would like to end on is the fact that all of us sitting in this room, be it physicians, educators, leaders, business partners, but most importantly, each and every one of us is or will be a patient at some point in our lives. Right. And this process needs you, it needs us. Every transformative and innovative idea surrounding healthcare and education and clinical training has actually come from patients, because in some way, somehow, some shape, patients have helped us to recognize that the way in which we've been doing it has not been okay. So I guess the challenge that I would like to issue to each and every one of us is to engage, to lean in as we are having this conversation. Think of when you fill out your evaluations or your Press Ganey or your session evaluations, and think, what is missing? What would I have wished that provider would have done differently? Because only by calling to attention where some of these opportunities exist can we be thoughtful about the solutions.
Great. Yeah.
Very well stated.
Yeah, well said.
Thank you. I don't have too much to add, except to say I think, like all of us, we're inspired to be living at this time and to see this level of transformation that is occurring in our country. I'm inspired by my students every day, and when we are going through change like this, it is an opportunity for leadership, for humility, and for learning. And I'm just very pleased to be engaged with all of you in this.
Yeah. Any final questions? Thank you, Dr. Sukin, Dr. Phillips, Dr. Coleman, Dr. Byington. Thank you as well. Great.